Okay, part 2. So we were just talking about AVR, AVL, and so now we're going to talk about the V1 to V6 and how the electricity is going. And I told you it's going to be, so it looks like it's going to be a 3-part now. Maybe more, who knows. So basically we have our SA node, we have our AV node, we have the all Perkins fibers and everything, and then we have the right and then the left branch. So V1 is right over here, V2, V3, V4, V5, V6. So as the electricity is going, it kind of, because AV, it looks kind of like this, electricity will kind of do a little burst a little bit, and then we'll come back here, and then we'll turn. And this is an important thing to remember, because, we'll put it right over here, V1 will sometimes look like something like this, as this will be very little. And the reason is this thing. Little part will go towards it, and that's that little deviation right over there. So it's that little deviation that's going over there, but mostly it will go negative because all the electricity will go the other way. V2, a little bit the same. Actually, we'll say V1, V2 because they kind of look a little bit the same. They'll have maybe a little bit, but if you look, they're kind of side to side. So now V3, see how V3 is right over here? So that means, again, rule number 2, where electricity comes towards me, positive, electricity going away, negative. Okay, so all this time that electricity is going towards me, let's do it in red, so that's V3. As electricity is going towards me, and I won't do the P wave anymore, I'm just going to do the QRS, it's just to understand that concept. So it will be positive as it's coming this way, but then it will go negative. So a little bit more positive than V1, V2, because all this distance where it's going to go towards it, but still will be mostly negative, because then between V4, V5, V6, all the electricity will be going away. Now at V4, we're kind of halfway. So V4 versus V3, and we'll put them side to side with different colors, is that I'll see mostly almost like an equal sign, and actually mostly positive and a little bit of negative, because now it's only V5. So that means that V1, V2, V3, V4 all will be positive, only V5 and V6 will be negative. And that will be kind of when it goes down. And then V5, V6, pretty much everything will be positive, hopefully. And we'll see the reason why that's, I say hopefully. So as it comes towards it, that's why you want to have V4, V5 mostly positive. If they're not, we'll talk about it in the next video when I talk about the approach. But this is what kind of happens. So this is why this is what a normal ECG would look like. So basically, the electricity will come. AVR, mostly everything negative. AVL, some positive, some negative. AVF, about the same thing. Sometimes they'll be like exactly like half-half, or sometimes they'll be different. And then after that, you come over here. V1 mostly negative. V2 mostly negative. V3 mostly it's kind of in between a little bit of positive, but a little bit more on the negative than on positive. V4 mostly positive, a little bit of negative. V5, V6 hopefully pretty much no negative, all positive. And lead 2 all positive, because everything goes between this and this, and lead 3 mostly on the negative side, and V1 kind of a little bit of negative. So now we'll talk a little bit about on our monitor, mostly, we put everything in lead 2 and V1. If you ever notice that we'll have like the first strip on lead 2 and the second strip on V1. And the reason for that is that lead 2, you want to see how the electricity is coming towards it, and which is in 90% of the time will always go the same way. And the reason for the V1 is that if you have anything that comes from the ventricle, then you will see it better. Why? Because, again, if you look at where V1 is in our heart, and I'll redo the pictures over here. So, what we're looking in lead 2 is we're looking at the electricity going like this, which is mostly what the electricity is going like that. But in lead 1, V1, electricity is going, because the stickers is right over there. What we're looking at is that if any electricity is going back up, I'll see it in V1. And how would I see it? I'll leave you a few seconds. So electricity, instead of going like this, comes mostly from the ventricle. So what would I see different in my lead V1? It will be positive. Because usually, because the electricity is going this way, everything should be mostly on the negative side. But if it comes to the ventricle, that means now the electricity is going towards me, not away from me. It will be mostly positive. So that's why we put lead V1s. It's mostly to catch VTACs and other VTACs or PVCs or any other rhythms that would come from the ventricle that comes towards you. So if you keep those two leads, you're pretty much sure of catching 95% of the bad stuff coming and monitor the good things. And so now that's where I'm going to take a little bit in a second. And why I've been talking about that is that we'll talk a little bit more about the 12 lead stuff. But let's say you have someone that have some abnormalities in, I don't know, let's say, again, it wouldn't be very in their environment, but we have someone that shows some abnormalities in their lead V4, V3, V4, so he's got a kind of an anterior MI going on or ischemia of some sort. If I examine lead 2, would I see anything? Would I see the progression of that rhythm? No, because lead V3s and V4 are right here. They're checking that zone. What I'm checking is the electricity going this way. So, because there's something cooking right over there, I should be checking that zone. And during one transport I did one time, that's exactly what it was. So the transport was an MI patient that was reperfused, so got TNK. And we were transferring because the TNK didn't work, so after an hour and a half, usually if the TNK doesn't work, blah, 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 blah. Anyway, we were transporting that patient. Well, I didn't monitor him in lead 2, because what's the point? My point was to monitor him where his MI was. And actually, if I remember correctly, it was V4. Well, interesting enough, so what you can do is either change, keep the lead 2 if you want, and then on your second one, instead of V1, now you can check V4. All you have to do is put exactly your stickers exactly where V4 would be on the 12 lead, but now you're monitoring that lead instead of this lead. So the brown lead would just go over there and you can check V4. Well, while I was doing that, almost while we were getting there, he did have more trouble in V4, and I was able to assess him. So, and it was interesting because I knew the concept but never really applied it, but this time it like it was right in my face. So lead 2 didn't show any change of the ECGs, but lead 4 you could see the ST elevation coming back. And then I know that this patient, something is going on with it. So that way your lead 2 can say, well, everything looks normal. Well, yeah, because this problem is in V4 and V3. So really important to understand that when you apply something on the patient, you need to understand why you're looking at this part. And if you have a problem in V4 and V3, well then don't monitor lead 2, or you can still monitor lead 2, but also monitor where his problem is, because that way you'll know something is cooking. So that was just a little side note for this. So basically, yeah, so there's 12 ways. So when you read the 12 lead, it's really about the electricity, where it's coming and when it's leaving. And leads, put it in red, I've been doing all the time. So this is your lead. Don't forget that the muscles has also different layers, you know, like you have the myocardium, and you have the exterior, and then you have another little pocket around it. So in the muscles, things can happen, and this is the difference between what we call a STEMI, so ST elevation, and a non-STEMI, is that a STEMI, pretty much the whole muscle. So, so this will be STEMI. The whole muscle is affected. So the electricity that is going over here, and when I say all the muscle, there's maybe some spots around there that are still producing some electricity, but you will see that elevation, that ST elevation from it. And then that's pretty much what it is. A non-STEMI, so, and STEMI, same muscle, could be only this part, or this part, or this part, whatever. But it's not the whole thing. And so now, I won't see the ST elevation, but I can still see some change, and we'll see in the next video how to check for those change. But the reason I'm doing this picture is that how would we see change? Very easy. Again, that concept of that, if electricity is supposed to go, if the electricity is supposed to come this way, and this is, let's say, V4, so that means that mostly everything should be positive and a little bit of negative. If I got a blockage over here, the electricity won't be able to come this way. So what it's going to do, the electricity needs to go where it can go. It will go around. Well, you see around here, that little space, what's going to show on here? What's rule number 2? Electricity going away, mostly negative. That's what you're going to see. So that means that in some time what you're going to see is either ST elevation, flip T's, change in this pattern of positive versus negative. And this is why, obviously this is simplified, it's a more complex physiology of it, but it's just to put an image in your head, is that the electricity is not going the way it should be. It's going away, it's coming towards. And this is why we do 12 lead. This is why it is such a great tool, is because we're able to see the electricity is going. But it's not just for non-STEMI and STEMI, and we'll see why. And this is the difference between a STEMI and a non-STEMI, is because of this, where is that, how much damage there is to this heart, so that electricity pass or not pass. So we'll go to the next video where we're going to explain pretty much the steps that I take when I